Good morning, everyone, and welcome to the 2020 series of free webinars sponsored by the Canadian Association for Suicide Prevention, the Quebec Association for Suicide Prevention, and the Centre for Research and Intervention on Suicide, Ethical Issues, and End-of-Life Practices at the Université du Québec à Montréal. These days were initially planned for a national conference on suicide prevention to be held at the Université du Québec à Montréal in Montreal, Quebec. However, because of COVID-19, the event has been rescheduled for October 27 to the 29th, 2021 in Montreal, with pre-conference activities being held on the 26th of October, 2021. Please mark those dates in your calendar and check out the websites of CAS, AQPS, or CRISE for further information about these major national events. Hi, I'm Lorraine Millet, Project Coordinator and Research Agent for the CRISE. Today, I have the pleasure of introducing Cécile Bardon, a professor in the Department of Psychology at the Université du Québec à Montréal, an Associate Director of the CRISE, as well as a researcher with the Chair of Intellectual Disability and Behavioral Disorder at UQAM. She will be speaking for 40 minutes, and then we will have a 20-minute question period. So if you have any questions during the presentation, please write them in the Q&A section that you will find at the bottom of your screen. If you have a French screen, and then it will be the Q&R. It will not be possible for Professor Bardon to directly read the questions, so I'll be monitoring them and reading the questions at the end of her presentation. The total time for the presentation and question period will be an hour, and we should finish no later than 5 minutes or so after the hour. Excuse me. Please keep in mind, though, all the presentations are being recorded, and you will have access to them in a few weeks from now on the websites of the three organizers, CASP, AQPS, and CRISE. With no further ado, I now invite Professor Bardon to begin the webinar.
Thank you very much, Lorraine, and I'm very happy to be here with you today. I'm going to share my screen so that I can share the PowerPoint with you, and we'll be going. There we go. There we go. I hope everybody can see it. Well, I'm going to be like Lorraine said, and sorry about my English. It's rusty. I don't practice enough, so please bear with me for a few minutes while it's coming back to me. I'm going to be talking to you today about the experiences we've had in working on developing and assessing and using clinical instruments to help suicide prevention in persons who have an intellectual disability or an autism spectrum disorder. We're going to call them ID or ASD all along throughout this presentation. Basically, that's this work we've been doing for a while now. I didn't do by myself, of course, and I want to say a special thanks to the team of co-researchers and students who have been working with me on that issue for a while, mainly Diane Morin, who's a professor here at UQAM. The CRISE has been a great support. The chair headed by Diane has also been very helpful. The Institut de Recherche, the IETSA also, and the UQAM have been strong partners. That's the research projects we've been doing on these issues have been financed by Canada and Quebec public funding agencies, and we've been working on that since 2013. And we have now 5 financed projects in our research program on that issue. And so that's the data I'm going to present to you today, coming from all these different projects. I just wanted to try and, move the bar elsewhere. Also, these projects have been carried out in close collaboration with the specialized services and rehabilitation services in the province of Quebec, who have been really very tightly involved with us and have been working very hard with us to put together concepts and instruments to help improve suicide prevention in their users and their clienteles. The Suicide Prevention Network in Quebec has also been very involved. And all these projects are based in a community psychology approach, which means research in partnership and working on improving people's sense of competency and hearing the voice also of those who are usually not heard. So basically what we've been doing is first assess the scope and intensity of suicidal behavior in individuals who have ASD or ID. Historically, it's been thought that those individuals were less likely to have suicidal behavior than other kind of clienteles or neurotypical individuals, but recent data has been showing that it's not the case. So I'm going to first show you a bit of information on that, and then we're going to explore the results of the studies we've been doing so far. So to give you a brief overview, and we have to bear in mind that these data have rarely been collected on large enough samples to be population-sized data and representative of the whole population. However, we know that in individuals with autism spectrum disorders, death by suicide is 3 times higher than in the general population. Also, absolute numbers remain low. Suicide attempts are very common, and suicide ideation are also very common. Up to 2/3 of people with an ASD diagnosis have had suicidal ideation in the course of their life. Regarding high-functioning ASD patients or persons, the numbers are even higher, with almost 1/3 of these patients having had a suicide attempt at least once in their life, which is very, very high. Regarding people with intellectual disabilities, the numbers are much lower, but they are still significant, with about 1/4 of the population having had suicidal ideation at least once in their lives. These samples upon which this data is gathered are quite small and usually located within a community and within people who receive services. So they might be a bit higher than in a global population, but they're still quite an indicator that something is going on and we need to take care of it. When we're talking about suicidal behavior in this group, one of the main issues we have is with cognitive abilities and communication abilities. Many of these persons have difficulties expressing themselves with words, so or the words don't have the same meaning for them as they have for other members of the community. So nonverbal indicators and terms are quite important for us to take into consideration when we're talking about suicide within these groups. So when we're talking about suicidal behavior in persons with ID or ASD, first of all, we're talking about thoughts that will not be observable if they're not communicated. So it seems obvious to say it like that, but many people do not communicate. So if we do not go and look for the information, it's going to be provided to us. So thoughts may be there and we don't know about them. And then we have direct verbal communication, verbal communication, like we see in many other groups in the population, like I want to die, I want to kill myself, and so on and so forth. And we have also, quite typical to this group, very indirect communications, like I want to join grandma, I would like to be dead, but there is no expressed intent as such. I want to go far away and not come back. We had a case of youngsters who said, I want to go and swim with the whales. And in that evening, he made a very serious suicide attempt. So language can be cryptid, and indirect verbal communications may be very important to look at. Text and social media are more and more often used by these people to express distress and suicidal ideation, because verbal communications are not always easy, so written one becomes a way to say something's wrong. Then we have non-verbal communication that may be quite common in these groups, like drawings that represent a violent act or a suicidal act, tombs, coffins, things like that. And in the non-verbal communication, we also have miming, people who mime cutting or mime strangling with their hands. It may be difficult to distinguish whether it's an attempt or communication of distress. So basically, the idea here is to take it seriously and act upon it, no matter what we think it might mean, whether it's communication or attempt for real. We have then self-aggressive behavior without injury, which is quite common too, like trying to push an object through the skin, like a spoon, a branch, any kind of object, swallowing non-toxic substances or pills without knowing the actual level of danger attached to these pills or substances, or trying to strangle oneself with hands or holding your breath. Some people are very physically impaired and bound to wheelchairs, for example, and sometimes holding your breath is the only way you have accessible to you to try and kill yourself. So even these gestures, although they're not dangerous, have to be taken seriously. And then we have self-aggressive behavior, and we fall back into the category of things we know in the suicide prevention community, self-aggressive behavior with injury or death. And I give you here a few examples of behavior that have been noted in specific persons throughout our studies. When we're talking about suicidal behavior and suicidal risk in these groups, we also have to be very aware of associated factors or indicators that can tell us something is going wrong. And if we ask a question, we may reveal suicidal ideation and suicidal intent. I've put you here a list of these items. They are available on our tools and website. I'm going to show you in the end. I'm not going to go through all of them because it's quite repetitive, but mainly they belong to all the categories that are here: cognitive, emotional, behavioral, somatic, psychiatric, on the level of the autonomic system, like sleep, appetite, and energy, loss of capacities for the person, and signs of hopelessness that can be observed in the behavior and discourse of these persons. So if you observe something like that in a context that we're going to describe later on, it's worth trying and dig in and see if there is a suicidal ideation or thoughts of death associated with them. They might be the only indicators you have that something is going on. So what are the specificities of persons with ID or ASD regarding suicidal behavior? Why bother trying to figure out how different they are and how specific they are, and why not apply instruments and practices developed for the general population, basically? So we know that they are slightly different from the rest of the population in their cognitions, essentially. The way people think about their life, think about death. Sometimes some people don't have a full sense of what death means. We can't consider that as a protective factor, because thinking that death is temporary doesn't protect you from trying to kill yourself and thinking you might be coming back tomorrow. So it may increase the danger of a gesture instead of being a protective factor. Not knowing about death as such, as being definitive, may make it difficult for clinicians to interact with the person on that matter. So we have to develop a specific vocabulary to talk about that. Concept of time may be different. So when we're talking about what happened yesterday, what's going to happen tomorrow, wanting to die yesterday, the last month, and all the criteria we have to assess recency of previous suicidal ideation and behavior may not be relevant for these clienteles because time doesn't work the same way necessarily for them. There are differences is also in emotions. Many of them have difficulties recognizing their own emotions, naming them, and understanding what's happening. So it's difficult to work on these emotions and explore them with them. Communication, as we said before, may be very different. So we have to take that into consideration. When words can't be used to talk about suicide, what can we use and how can we do it differently? The social context is also quite peculiar, specific in the sense that these persons, I'm going to make it, these persons require quite intense support and have issues regarding autonomy. So these may play into increased risk or decreased risk or surveillance, so the type of interventions we can implement with them. Impulsivity, substance use, recurring suicidal behavior are all things we are used to work with in the general population when thinking about suicide. For these populations, impulsivity is almost a trait of functioning for many of them. So how does that interact with the suicidal risk specifically present in that person? Substance use also may be very differently treated and used. Many people don't have, who live in institutions, for example, don't have a substance use problem, but many individuals with ASD self-medicate with alcohol or drugs, and it has quite a different effect on their brain and thought process and everything. Recurring behavior is a very, very big problem in this population. And like I said, when you don't think time the same way, how do we interpret the recurring suicidal behavior within a time frame that may be so different for the person? So all this makes it so that instruments that have been developed and used for the general population are not completely adequate to help these specific clients having ASD or ID. So to answer these issues and these problems that the rehabilitation and suicide prevention services had, we developed what we call the IDAS. I don't know yet how to pronounce that in English. I'm sorry. You're going to be better at that than me, but it goes for intellectual disability, autism, and suicide. So IDAS process, because it's a clinical process, or it's a process to support the clinical judgment of people working with clients with ID or ASD, or working with suicidal clients to help them better understand and act upon the suicidal behavior of this specific population. So basically, it looks a bit like that. We identified 4 areas of assessment, and each area of assessment comes with specific recommendations for intervention. And they are separate into first screening, and I'm going to detail that a bit more later. So first you have to screen the person, identify that this person really has suicidal behavioral or associated factors or elements. And then how do you manage the suicidal episode or the suicidal crisis? And then how do you reduce the long-term and underlying risk factors and improve protective factors? We've done a longitudinal process like that because, fortunately, in the rehabilitation services, they have access to the person over a long period of time. So they can screen, sorry, I was looking for the word. They can screen, they can manage a crisis, but they can also have longitudinal follow-up with a person that helps put things in place to reduce the risk of further suicidal episodes occurring, knowing that, like we said, they have a tendency for recurring suicidal behavior that's very high. And the idea also is that for every time we assess something, it's with the purpose of acting upon that assessment. And that action also will change the situation, and then we need to assess again to see what's still needed and what needs to be adapted. Hence the dynamic structure of the intervention, basically. And intervention combines assessments and action intervention together. So first, a few words on the model we have developed from the studies we've made of the suicidal risk, and this model is available on the website of the project and the instruments we've been developing. But basically, it falls into the category of diathesis stress models. So it's quite classic structure of suicide models. Basically, it means that we consider suicidality as a construct that occurs over time from developmental elements, but also experience lived by the person and current events. So it's the accumulation of all these things that bring a person to a point when they are fragile somehow and could do a suicidal gesture. Compared to general population, we added a few factors to these general models that we found in the studies we've made, and also who are more and more described in the available literature. So we add to a global model the general abilities and functions, which is the big blue square in the model here, of the person, all the cognitive, affective, social abilities. Like, for example, people might be more suicidal, more often suicidal, if they are generally anxious, if they have aggressive behavior against objects, verbally or against people, if they have cognitive rigidity and if they need to exert strong control over their environment, if they have obsessive thoughts about death and dying or suicide, if they have very strong rituals and routines, those people may be more susceptible to the accumulation of other risk factors that are going to play on that and increase risk for suicidal behavior. If they have difficulties in recognizing and naming emotions and symptoms, and etc. On that come the impact of risk factors, like we know in other groups. Isolation is very, very present in this group. Difficulties with social interactions, of course, especially with those with an ASD. Lack of social support is also very important, but also avoidance of social situations. And in the ASD community, we talk more and more about the impact of masking, which is something we observe in people who try to pass at somebody who's neurotypical and try to mask their symptoms and their difficulties, and that drains a lot of energy and induces exhaustion and emotional distress in them. Huge incidents of abuse, negligence, aggression, conflicts in the history of these people, trauma, bullying, family dysfunction, adaptation problem, mental and physical comorbidity, externalized behavior, like we mentioned, low self-esteem, and existing self-harm. Self-mutilation is very present in this group and population, so that's a factor that's often associated. What they call external locus of control, so not being in control of your own life, which happens a lot in these clients, and not accepting the diagnosis of ID or ASD, or having close persons who do not. Repetitive failures and negative experience that add up are another risk factor. Sensory sensitivity, that's very present in some cases, and trait impulsivity. All are factors that have been seen in our studies and other studies associated with suicidal behavior. In protective factors, those who have a lower planning abilities in general are less likely to be able to plan a suicidal gesture, but that doesn't protect them at all from distress, ideation. When you have various ways to express yourself, express emotions, that helps too. living in a very adapted environment, having social support, etc., are the factors that can help protect a person. In matters of stressors and triggers, we have identified big events like a conflict or big change in the person's life, but we also have identified what we call accumulative small events that may seem mundane to someone else, but in somebody who's got very small control over their own lives, those little events can add up and take a huge part in their distress and suicidal behavior. The accumulation of all these risk factors and these moments and trigger events bring a loss in the person's equilibrium. They're going unbalanced, unhinged, and they feel powerless, they feel helpless, they feel dependent more than usual, and they feel hopeless. And if they have cognitive elements that we're going to talk about associated with suicidal option, then we have a risk of suicidal episode that manifests itself in the signs I told you before, like behavior or associated factors. We've put together the idea of the suicide option for these persons and these participants through the question of how did that come to their minds to think about killing themselves like that, and it comes with the experience they have with death. And some people have been told, oh, you know, grandpa is dead now, it doesn't suffer anymore. Well, if I don't want to suffer, maybe I should be dead like grandpa. So these kind of cognitive things that have been put in their mind unwillingly, completely unwillingly, may fuel the idea that it's okay to kill myself, to stop suffering, to join someone, or, you know, things like that. The way people understand death, the previous behavior they had, the reasons they have to consider suicide or not consider suicide in a general sense may fuel cognitions when it comes to them experiencing the same situations or event. And in many cases also, and we don't have time to go into that, but in many cases, although suicidality or suicide ideation or verbal communication may end up playing a role into the interaction they have with their surroundings, whether it's close person or clinicians. And we have to understand how it came about to be used as a manipulation tool, and I put that in brackets a lot. So basically, that's the model we've put together, and that helps us understand where to look for indicators and how to act upon them to try and reduce suicidal risk for the person. I've put here a few strategies we've identified to collect relevant information on suicide risk in person with ID or ASD. I'm not sure we have much time left. Lorraine, can you tell me how much time we have?
Yes, so you have, you got 17 minutes to go.
Oh God, we got to rush. It's me, I'm always over talking. So basically, overall advice on how to collect information, because we can't have specific questions tailored and prepared in advance to assess risk, because every person you have in front of you is going to be slightly different from the other one, and some will understand open questions, some won't, some are not going to be verbal, some are going to be. For some of them, words don't mean exactly the same things as they do for others. So the person who's doing the assessment and doing the suicide prevention plan basically has to be very familiar with how this person specific is functioning. But there are general advice and general attitudes and behavior that as clinicians and workers we can have to help assess and intervene properly. First, use diverse communication strategies and sources of information. Like I said, some may answer to direct open questions, others need to be observed. You may also want to have a conversation more than formal assessment within a normal activity that the person has in a daily routine, for example. You may want to use visual support like drawings, pictograms that are quite often used in intervention with this type of clientele. Your attitude should be caring, warm, reassuring, patient, welcoming, and very adapted to the person's emotional level at the time of the interaction, and be very aware of what they understand about their own emotions, to try not to put words into their mouth and or into their experience without hearing it out in the first place. Validate communication and help seeking. Many of these clients will feel inadequate or will have fear to be told off because they were suicidal. Validate, it's okay. I'm happy that we talked about it. I'm happy that you mentioned it, because then we can do something about it. So validation is very important, and reassuring the person is very important. I've put here some facilitators. You can look at them later. There is no problem, but really it's mainly adjust to the person. Use communication strategies that are familiar to them, and be very sensitive to non-verbal communication, because for these people, non-verbal cues may be as important as verbal ones. So that's very important. Things to avoid: put words into their mouth, suggest things, disapprove. And the examples I've put here, unfortunately, are things that I have heard being said and done, and I want them to stop being said and done. So I've put that as example. Stop interrupting the thought process, tolerate silences, etc., etc. Other things to have to keep in mind when we do assessment and intervention: some of the clients tend to acquiesce, to say yes. They work very much on the assumption that they need to understand what you want and give you what you want, and saying yes sometimes is a way to give you what you want and not expressing what's happening really. So it has to be taken into consideration when exploring suicidal risk. Many of them will refuse to collaborate to the assessment or intervention, especially after the peak of the crisis is over. They will feel ashamed about their behavior or afraid of being sanctioned. So they will not want to collaborate into planning intervention and exploring further what's happened. So really establish an environment where confidence and tolerance to discussion can be built. And never, ever forget to do follow-ups. After the crisis is subsided, it's very important to keep on working with the person to see if what we've put in place worked, and to see if we need to adapt what we've been doing previously. So these are some key elements to keep in mind. And I know I'm going too fast, but all this information is available. So screening a suicidal individual with IED or ASD, if we go back to the first picture I showed you of the model of intervention we've put together, we are in the first point of entry, basically regarding suicidal prevention, and we've separated that from the overall suicidal episode management, because screening can be done by people in the usual settings in which the person lives or works or studies or has leisure activities and everything like that. So we put it on a separate process. So basically, the screening aims to identify the presence of suicidal behavior in the person and orient action for suicide risk assessment upon this identification. It can be performed by trained gatekeepers in the community, which is what I said. It looks like that. So what we've done is we've put all the indicators that we've identified in our studies and in the literature regarding what consists a suicidal behavior or potential indicator for suicidal behavior in a person with AD or ASD. So all the blue boxes are information provided to the person who does the assessment, and all the white boxes are the ones where you're supposed to document your clinical process. And the clinical process is based on very basic things like observe, decide, act. Never act before you've observed, you've decided upon what to act, and never decide without observing what's happening. It's basic to say, but when people are scared because somebody is thrashing around and saying they want to kill themselves, we tend to use shortcuts and rush into action, and that's when we overreact sometimes. So all the instruments are divided this way: observe what you've seen, the decision you're making about what you've observed, and how you're going to act upon this decision you've made. So in this screening phase, it's really a matter of saying, oh, there are some cognitions that have changed. The emotion of the person is not like it normally is. Is not sleeping well, and this kind of events also occurred. We need to go further and make an assessment. Is there a suicidal component to the person's distress at the moment? Once this is done, we can go into the management of the suicidal episode, and we've specifically named it like that because managing a suicidal episode is assessing the level of the presence and level of ideations and actual danger for a suicidal attempt, and acting upon that. So again, observe, decide, act is all integrated into a single overarching clinical process. And we talk about suicidal episodes because in the rehabilitation community, people are very much used to deal with crisis, behavioral crisis, and social crisis. And a suicidal episode does not always manifest itself through outside behavior that you can see. And the term crisis in this community is so much anchored into explosive behavior that it associates the idea of suicide to also an explosive behavior, which is not always the case. So in working with the community of rehabilitation services, we decided to use the word episode so that it disjoins somehow the relationship between the idea of a crisis and suicidality, and it makes it more easier to see suicidal episodes. And like we said, screening can be part of the management of the episode, but it also can be separated, but we've put it here together too. And the assessment comes with strategies for action. And we've developed a complete set of strategies to act. Suicide risk assessments is used to all the elements that were here, document what's happening, but specifically to guide and support intervention. An intervention should be to ensure safety, prevent an attempt, increase hope, etc., etc. An intervention should be tailored to the result of the assessment. And this is very important because sometimes we have people being sent to a hospital by ambulance after having suicidal ideation, but their trip to the emergency room was not necessary because they were not in an immediate danger, and an adequate intervention could have been made in their living environment without having the trauma of going into an ambulance and going to hospital and being in this very stressful environment that is unfamiliar and everything. So the idea here is to always adapt the intensity of the intervention we put in place when there is an episode to the intensity of the danger that this episode really has with the person. I'm not going to talk about that. We don't have the time. Here again, the suicide management, the suicide episode management structure and clinical process followed the same structure I showed you before. Basically, we have information to collect about the episode and the risk factors associated with this episode and with the trigger events and the environment in which the episode takes place. And then we can decide if there are ideation, the severity of this ideation, if there is a risk for suicide attempt, if there is planning involved, and etc. And that should help us decide the level of intervention that should be implemented with this person. And there is a specific attention made to wrapping things up and concluding properly the management process, where we assess with the person what they understood, how they understood it, and if everybody agrees with the action plan that's being proposed, and how the person feels about it and is able to implement it with you and with other partners. Once the suicidal episode is contained, in brackets again, and the distress level of the person has gone back down to functioning normally, then we have the time to think about what brought us here in the first place, and how the risk factor builds over time, and how the cognitions regarding the possibility of doing a suicidal gesture built over time in the person. So we are here in the final leg of our process, in the final step of the clinical process, where we assess long-term risk factors and the suicide option, like that I showed you before, and associated intervention that can be implemented with the person again. So here again, assessment means to complete the information we have, identify distal risk factors, and describe and understand how the suicidal process in which the person is engaged came to be. Like, what are the risk factors, what is suicidal option is, and what is the potential pattern of recurring suicidal behavior, which we know is quite present in those clients. And intervention should be aimed at these factors. How do I deconstruct the pattern? How do I reduce the impact of those risk factors? And how do I work on cognitions and the social impact of the suicidal ideation? In the instruments we've developed, you have strategies for intervention on all these dimensions and all these factors. So here again, this is how it looks, to document what's happening and what's being done, because we know that without proper documentation, we keep on repeating the same things again and again and again. And that's how most patterns of suicidal behavior come to be, because we've only acted upon the incident itself, the suicidal episode itself, and then we prepare the table for the next one, and the next one, and the next one. This part of the process aims to deconstruct this repetitiveness and work on really what brought the person here. When we are acting upon these dimensions here, we don't need to talk about suicide anymore with the person, since we're working on really underlying factors that have brought us to the suicidal episode. And here again, observe, decide, act upon the three dimensions I mentioned. So in conclusion, and I think we're going to keep the time, we now know that individuals with ID or ASD have high levels of suicidal behavior or associated behavior and associated signs. They have very, very high level of distress, and they have very, very, very high level of comorbidity with depression, anxiety, and other psychiatric disorders. So emotional distress is very present and should be taken care of. And suicide is one of the indicators of this distress. Suicidal behavior can manifest themselves in very varied verbal and non-verbal ways that can be very difficult to understand and identify for people who are not familiar with the person. So it's very important to work in teams around these issues, and recurring suicidal behavior are really a worrying issue and a key issue for us. We know that suicide risk assessment instruments developed for the general population are not very adapted for these groups, and we need to work towards developing things that work better for this group and are well adapted also to the way of working of rehabilitation services, who usually have the charge of this person. It's very important to consider suicide assessment and prevention in the longitudinal process, and not just care for this suicidal episode, but consider the whole process of how it came to be and understand the episodes within the patterns when there is one and within the history of the person in order to be able to act efficiently on all these dimensions. Because we found, and it needs to be validated, but it seems that the severity of the suicidal behavior is more associated with the severity of long-term risk factor than with the severity of the trigger event itself. So people who have lived experience of trauma, abuse, severe mental health issues are more at risk of doing an attempt than have ideations when something happens that triggers suicidal episodes. So it's really important to take care of these long-term factors. Collaboration and interdisciplinarity are key concepts and key issues in suicide prevention, especially for these clients, because you can't be an expert of everything. The suicide prevention community is usually uncomfortable with these clients and with the IDASD clients, and the IDASD community is very uncomfortable with suicide. We need to meet somewhere in the middle. And the IDAS process that I've showed you today, that's the products of a few years of work, and still we're still working to validate and improve it still for the 10 years to come, I think, could help you screen, manage the episode, and reduce the long-term risk factors into a coherent clinical process regarding suicide prevention. Always, intervention objectives must be aligned with assessment result. I know it sounds obvious, but when we jump into a situation where we are uncomfortable, usually we bypass our ability to assess properly. So assessment is key, and intervention should always align with assessment. Suicide prevention activities should be embedded within the usual care routines of the person. These people have many professionals involved in their caretaking. That gives us many opportunities to add suicide prevention components to the usual care that's provided. Various activities should be combined within the comprehensive strategy, a comprehensive suicide prevention strategy. We don't just do one thing to help. We construct a plan over time. And all the general care and support practices that are being put in place, usually around the person, can include those, incorporate those suicide prevention strategies and make it part of the normal care given to the person to also take care of that aspect of their experience. And I think that ends what I wanted to say. I realize I've been talking fast. I'm sorry about that. You can write to me. I'll be pleased to answer if I can. And to know more about the instruments we've been developed, you can go on the website. The name is here. The English translation of the instruments is brand new. It's not a few days old. And we are in the process of translating the website as well, but you can find the English versions of all the clinical instruments there. I don't know if you have questions or comments for us.
Actually, I do have two questions for you. One of them is it important to establish a relationship with the individuals prior to screening and providing an intervention?
In the best of circumstances, yes. Because trust is we know that for anybody, trust is important. For these people, trust is even more important. And the idea of and trust and familiarity, because for many of these patients, especially ASD patients, social interactions are difficult. So socially interacting with a new professional on such an issue sometimes may be a deterrent. And that's why many of those persons with ASD, high functioning ASD, use online services more and more, because they don't have to interact with somebody verbally or directly. So having a trusting relationship is very important. I'm very aware of the fact that you can't always have that prior if you are involved because there is a suicidal episode. But before you can go anywhere and assess properly what's happening, you need to build this trusting relationship with the person. And most of the time, you're going to have the time to do it because, you only have to act quickly if the person presents very high level of immediate danger. Okay. In all the other situations, you have a bit of breathing space upon which you can build to construct this initial trust. But that's a key element. And also trust and also adapted language is also very important. And to me, the two go hand in hand because it's only once you get to a feel of this person a little bit that you can adapt your language to where they're at as well.
There's a second question for you, Cécile. They're actually, one lady's asking, is there any training that is planned for les intervenants? I don't know how to say it actually in French, les intervenantes from CLSCs and so on.
Yeah.
So I wanted you to answer that.
Yeah, well, we have, I'm very happy to say that we've been training our first batch of rehabilitation and suicide prevention colleagues and professionals to work with these instruments in French. For the moment, the training only exists in French. And it comes with, since we've been insisting quite a bit, and maybe I haven't hit on that nail too much today, but working as a team and never being alone in facing the suicidal behavior of a client is key. And to make sure that people work in teams, we want the suicide prevention abilities and competencies to become team abilities and team competencies. So the way we do training is by having mentors in clinical teams and having the clinical team learning together how to use the instruments and the suicidal and the clinical process, so that they can support each other and they can learn from a colleague's cases and patients. So that's the training program we've put together, and we've trained our first batch of mentors 2 weeks ago. And there is another training session that occurs in January, and then another one in June or May, something like that. And all the now I'm not involved in this training anymore. It's all being appropriated. Do we say that? By the rehabilitation services in Quebec. So for those who know them, the SQE-TGC is now the curator of the training program, and they are the ones who are providing it freely for the rehabilitation services in the province of Quebec. For outside the province, we are not there yet, but if you have ideas, I'm all for it.
I actually have another one. We have time for another couple of questions here. One of them is, what a wonderful tool. Thank you so much. Would you have a checklist as a tool accessible for those dealing with crisis of suicide calls and not in person in order to screen better over the phone? I thought you'd like that question.
Yeah. And Lorraine is laughing because that's something we've been working on very hard for a long time, not to use checklists, because there is a side effect, I would say, to the use of checklists, because we've observed that especially when people are not comfortable with the situation, and in the suicide prevention community, we're not comfortable with ASD clients, and vice versa for the ASD community. But using a checklist sometimes can lead to clinicians, whoever they are, to delegate their clinical judgment to the checklist. And that is a dangerous slope. So we want for the tools we've developed to be supportive of clinical judgment and not like a quick, there can't be a quick fix on that. But your question, from what I understand, concerns suicide prevention services who may have somebody calling that we realize has an ID or an ASD. For that, we're not there yet to develop specific instruments because there are so many issues with that. Many people do not self-identify as ID or ASD. It's something you may notice from the type of interactions you have with them. So we have to know more about that before we can do something like that. Since we know there are many people who use the mainstream services, my advice would be to establish close relationships and collaborations with the IDASD services in your area, and develop together cues based on the IDAS process or other things. I don't mean to say that we have invented the absolute grail of things. It's still work in progress, but work together on cues and elements that could help you, both the IDASD services and the suicide prevention services, identify the ones who may need this specific help. We do not have checklists yet. I'm not keen on developing one. I'm more interested in developing collaboration between services who don't usually talk together. I know it's a frustrating answer, and I'm sorry about it.
Actually, and just to add to that, I guess one of the concerns, especially Dominique Chabot was just mentioning, that Autistic Canada receives on average 3 suicide or crisis calls a week since the pandemic. So there's, as you could well imagine, there's a lot of concern about that because they're looking for some kind of instrument that they're able to intervene very quickly with some of these distress calls.
You can use the screening and the suicidal episode management sections of the IDAS for these callers, the same way you would face-to-face, basically, with them. Like, you know, it gives you cues of things to look for and things upon which to act. And if you go on the website and find the intervention manual that comes with it, it gives you ideas of what type of interventions you can do with them. Obviously, over the phone, it's less easy because you don't have the follow-up capacity with them, but you can still put things in place like a safety plan and things like that. And there are examples of such safety plans in the I don't know how to call it, the instruments, the process that's on the website.
And there was just one last question I'd like to share with you, Cécile. It's very specific, however, so I'm not sure how you'll be able to answer, but it's one of the participants just saying, in youth, would you say that there are I'm sorry, I have to rephrase this. Actually, she was just referring to the fact that a youth would be saying, I don't want to grow up. Would that be kind of a sign, a distress sign that should be, you know, addressed? And could that, you know, remotely mean a distress sign on suicide ideations or something like that?
Without any context, it's very difficult to answer that. But somebody who says, I don't want to grow up, I would investigate what's going on and explore. What do you mean by you don't want to grow up? First, well, like for everything, the first thing is to not to project what we think the person means on what they say, but really go and explore what they actually mean by that. When you say you don't want to grow up, what does that mean? You know, for somebody who's a preteen, for example, it might mean that they don't, if it's a girl, she doesn't want to have breast growing. If it's a boy, he doesn't want to have body hair or some sort. It may be some insecurity about puberty. We don't know. If we don't explore it, we don't know. And I think that's one of the key messages I want you to remember. is that we can't infer anything with these clients. We need to explore and ask questions to know exactly what's going on. So basically, somebody who says, I don't want to grow up, says something. Now we need to know what it says, and we can't infer it says something about suicide, and we can't infer it says something about puberty. We have to ask, and the main thing is really to explore. But if we explored many things, and the person keeps on saying that, then we may want to ask directly, you know, are you thinking about dying or killing yourself because you don't want to be older than you are or growing older than you are? There's nothing like asking the question. Because we don't ask because we are afraid of the answer most of the time, and we don't know what to do with it. And the idea of the work we've been doing and others have been doing is to make us less afraid of the answer, because we give ourselves tools to act upon it, and then we can afford to ask the question, basically.
Exactly. Well, thank you very, very much, Cécile. It was very enlightening.
Very welcome.
A lot of people that were very grateful for this presentation. I just want to please keep in mind that all presentations are being recorded, and you'll be able to have access to them in a few weeks from now on the websites of our three organizers, which is CASP, AQPS, and CRISE. And thank you so much for being present with us. And again, thank you, Cécile.
Thank you very much for having us.